So today we're going to go over lateral mass fixation and laminoplasty, some nuances. Having been doing this for a number of years, I've kind of devised a lot of little tricks to kind of help with these procedures. So we know that, lateral mass fixation is well accepted now, and the risk of complications are low and the fusion rates are high when performed properly. Nerve root injury is exceedingly low at 1%, and I can think in the bajillion levels I've done, I've never had a nerve root injury, so I think it's even lower than that. And the case of vertebral artery injuries is also low, and I've never had one from a posterior technique, even in the setting of doing reductions of traumas. And we know that, the incidence of rod pullout, screw or plate breakage, or screw loosening is also exceedingly rare. So the question is, how can you, start doing cases like this using this powerful technique, and also like this, and knowing, when to deploy or employ one particular technique. So we'll go over some things today. And I'm going to start from an outside-in approach, and I like to think about the back of the neck as follows. We got this one thing here. We got a bony prominence of, C7, T1, and those areas, and those are pretty proud. And so what I've done over the years is I've modified my incision technique, and I plan a lazy S to avoid making an incision directly over a bony prominence, which can ultimately cause trouble. And typically, what we see is if we do these, it heals up nice. And what we want to avoid kind of is this, and this is what we see from time to time. You have sort of thinner patients, somewhat cachectic, and they have this bony prominence, and these always are rode through on a Friday afternoon when you're trying to leave town, and then you have to deal with it, or you end up getting one of your partners, which is never fun. So we've all seen that from time to time, and it's a horrible thing, and they take forever to heal. And of course you run the risk of getting a deep infection and having to remove hardware and so forth. So this lazy S technique I've been using probably for, 7 or 8 years now, and I've had a great success with it. So we don't want that. And the reason is, when we think about this, even in this picture of Bob Easlack at the gym last week, I noticed that, when you look at how the trapezius comes together in this diamond shape, there's really scant musculature sort of over these bony prominences, and it's more just like a tendinous fascial sheet in that area. So again, it's at very high risk. This was a case I did a while back. It was an oncology case in a really thin person, and I had to do an extensive fusion on this individual. But coming in here, I actually planned the incision such that it didn't overlie any of the bony prominences, even in the mid to upper thoracic spine. And so let's play the video. And this is what I do in the OR.
At the onion, the ignon, midline, 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 midline. Make a nice straight line like this. And then around here, go like this. That's where we go.
So that's how I do that. And again, when we sort of look at this, the muscular tendinous connections here are really thin, so there's not a lot of muscle overlying that. And so when I do this opening, I'll separate every single muscle in an individual layer. And the muscular dissection, I'll stay in the midline, and I'll tag these muscle layers such that, like a plastic surgeon does. So when I come in later to close it, these muscles are individually layered and tagged. And here's just a video of how I'm pulling up the trapezius in its own layer during the approach. And then as we get a little bit lower, we have the serratus posterior and the rhomboids, depending on your layer of dissection, but I'll pull these off in one layer. And then as we get down to the deeper dissection, we have the semispinalis and splenius capitis. I'll remove those. Those will usually come over as sort of one cluster of muscles, and I'll also tag those muscles. And then as we get deeper, We have the multifidi, the semispinalis, the deeper versions, and the spinalis there. So I like to separate all those, and I'll close those on the way out in a similar fashion. Then we get down there, this is kind of what we're going to start seeing. And we have to think about sort of the areas at risk. And as a new fellow starting out, if you haven't done a lot of these, there's a lot of things that you want to do and not do. What you want to do is avoid violating the facet joints. Okay, so you get into those. If it's not a level you're going to fuse, then that segment's going to be at risk for degeneration if you violate the capsule. So you want to avoid also bovie action sort of over the edge of the lateral mass. There's this rich venous plexus that lives over there, and once the bovie gets into it, it starts to bleed. And if you try to chase it with the bovie or bipolar, it still continues to bleed. So the answer is you just squirt some Surgifoam in there, Flow Seal, whatever you have, and then just pack it off with a cottonoid and just try not to chase that. The other thing you want to avoid is the interlaminar space. So as you're doing your dissection, come down, stay right on the bony elements and avoid going in here because I actually have seen somebody get into that before, and it's kind of a mess to clean up. Okay, and so just that. Also know your anatomy. Understand what are the various parts of the vertebral body, understanding the relationship between the foramen transversarium, understanding where the pedicle is, and understanding where the neuroforamen is. That's all key to doing anything in spine surgery, but particularly the neck. And I would even say, I think somebody presented a case last week of doing C1-2 is really understanding the relationship of the vertebral artery and the venous plexus and so forth, just so you can be as safe as possible. Sort of looking at this, so when we go to instrument or lateral mass, there's a couple key landmarks. One is the lateral mass laminar junction. I'm going to actually get my pen out here. Laser pointer. So understanding this junction, and visually you can see it as it transitions from one to another. What can be distorted though is that with significant pathology, these sort of landmarks can kind of get altered. Sometimes patients have rotational issues going on or something like that, and that can confuse this. And then what you do is you basically make like a checkerboard out of this. You dissect this medial lateral and inferiorly, and that's going to be kind of your playing field for your instrumentation. And why that's important is if we look at where the vertebral artery lies within this, it's going to be sort of on the inside portion of that midline, and then the nerve root is going to dip under here like this, and it's going to go into these bottom two fields. So without having X-ray vision and being able to see where these things are, you can gather where they are based on your understanding of anatomy. And then, of course, medially we have our spinal cord. And then the other thing we need to take into consideration is the rise and pitch of the facet joint. It changes at every level. And why that's important is when we go to do the instrumentation. So there's a number of different techniques that have been described over the years, and they all have a different trajectory of screws. And I think Maggerl is probably the one that we use most often, shooting in sort of an upward and outward configuration. And I think that's the easiest way to think about it. Trying to remember angles and so forth. They got to be 25 degrees this way and 40 degrees that way is often challenging. So I think understanding that you want to shoot sort of up and out is the way to go. And if we sort of look at where we're going to put our entry point for these, it sort of changes with each trajectory. And there's if we sort of look at sort of the numerics of all this, each one of these has a different angulation and where you're going to go. I think commonly most of us now use, the Dan Roux technique, and that's, starting point is a millimeter medial and a millimeter caudal to the center line of the lateral mass, and aim towards the upper and outer corner of the lateral mass. And that basically will get you there all of the time. There's another interesting device, and I think Dr. Mundis probably had a hand in sort of the commercialization of this. And this is this little pickle fork that you're going to stick into the facet joint. So you open the facet joint, you stick this in, and the tongs of this will actually, you know, ride up along the sort of angle of the facet joint. And then what you can do is use these prescribed drill guides to end up cannulating the lateral mass. And so that's using the drill device of this. You can see the tongs at the bottom here into the facet joint, and that's the drill going in, and it's shooting in that upward outer roux type fashion. And there it is, palpating this. So it's a pretty slick way to do it. And I've used this a bunch of times. And the other thing that's nice about this is it also has a central core where you can drill out the facet joint and then put in sort of a DVM pellet to help increase your surface area for fusion. I would say sort of the one downside of using this is if you have particularly spondylotic facet joints that are overgrown and so forth, or ones that, you know, are really sort of lumpy, bumpy. You have to do a lot of work to get this in, and it can be challenging. Another nuance with this is when you get it in, you got to make sure it's not slipping and sliding if the surface of the facet isn't exactly flat, because then this isn't going to be in the trajectory you want it to be. Because ultimately you want like pretty looking constructs like this, you know, with everything sort of shooting in that direction, and obviously you want it to be safe. So when we get down here, we're going to make that initial delineation between the lamina and lateral mass. I'll mark these things out, and I'll usually do it with a bovie, and then I'll plan my entry points. So if there's any irregularities in the facet, which we oftentimes see, they're all arthropathic and overgrown, I'll resect them either with like a biting pituitary, or I'll use a 3mm matchstick. Now, another little nuance I do is I don't make the entry point to these with the matchstick or AM8 or whatever it is if you guys use the Medtronic version, but I'll use a smaller drill bit, because when you lay the drill on its side, you're actually creating a bigger hole. So most of us use like 3.5mm screws for the lateral mass and 4mm diameter for bailout. And if you lay the 3mm on its side, you actually end up sometimes making a divot that's bigger than 3mm. And I like to have that nice screw cortical bone interface, so I use the smaller drill to start. And the other thing I'll do at this point is I'll line up all the entry points such that, you know, your screw head tulips aren't all zigzagged up here, and then you're left with sort of, you know, the conundrum of trying to bend a rod to get it to fit. So I'll make sure I do that as well. I have used navigation for some of these. We have a 7D, which is kind of fun. And, you know, it's more for, like, I just think, repetition of using it for more complicated cases, but you can, with that, go and line these up, particularly, you know, when you're trying to get your C2 screws, your C2 pars or pedicle screws to line up with the rest of your construct. It's also helpful, you know, because the T1 screw has a pretty lateral starting point, and so oftentimes, you know, you've had to use these sort of offset connectors, and so you can, you know, hedge this a little bit medial, and you can make these that they're contoured such that you can run, you know, one rod without having to use, you know, the offset connectors. And again, this is sort of the trajectory we end up taking, you know, given these starting points. Okay. So I'll use a 2.4mm drill guide, and I'll drill it to the selected depth. A lot of times I'll start, you know, 10 to 12mm, and if I want to go bicortical, I'll work my way up with 14. And then what I'll do is I'll palpate this with a ball tip probe, and then afterwards, you know, I'll tap these. And I do sort of all of this heavy lifting with bringing in these sharp pokey things into the wound before I do my decompression. You know, because, you know, the more times you make passes over the cord, the more likely you are to, you know, drop something or inadvertently poke something. So I'll do all this before I, you know, proceed to the decompression. So another thing we can do, if the lateral mass is dysmorphic, then you can sort of obviate the trajectory of you know, the facet by sticking a number 4 Penfield into the facet joint, or sometimes I personally just use the Bovie. If it's severely dysmorphic and compacted, which we sometimes see, you know, I'll just skip that level, so you know I get all my screws to line up and such. And so this is, you know, sticking something in here, and that's the notion of that, you know, device that Orthofix makes, is, you know, by putting something in the facet joint, you're going to naturally get things to line up. Because you can see when you get down lower in the spine, like the C7s are really steep, C6 can be steeper, and these are sort of a little bit easier to detect. But by putting something in there, you know, you can just visually lock in the angle of that you're going to be shooting for. And so then the next step I do once I have all these pre-drilled and tapped is I'll take down the inner spinous ligaments. If I'm doing like a 3 through 7 lami, I'll take down between 2 and 3, and then I'll take down between 7, 1, and I'll usually do dome laminectomies up at the top here, just so I have a bigger interlaminar space to get into the ligamentum flavum. A lot of times when you have patients positioned on the table, these will kind of like overlap one another, and so that just makes it easier to get into the canal. Do the same thing down here. And then when we get on to doing your laminectomies, there's a couple different ways to do it. I usually use a matchstick. I know I've heard, I think both Bob and Greg or the fellows say that they've used the bone scalpel or Misonics to get in here. Other people I've seen use, you know, the craniotome side cutter. It's kind of dealer's choice, whatever your comfort level is. I've used the matchstick. I've used it for years, and so I'm pretty comfortable with that. Whereas though I use the Misonics for everything else, including like you know, if I'm doing a PSO or something, I'll use that to do the vast majority of my resection, just to cut down on the bony bleeding. So what I'll do is I'll usually start at the bottom end, and I'll start to paint through. And the more you use the drill, you know, the more comfortable you are with it. But I'll sort of paint along that line. I'll go through the outer cortex, the inner cortical layer, and then, you know, with the drill bit I use, from Stryker, you can actually drill right down onto the ligamentum, because the sort of the tip of it won't pierce the dura in theory. In theory, I underscore. And so I'll paint my way up, I'll paint my way up, I'll paint my way up, and paint my way up, get all up to the top. I'll go on the other side and do it, or pass the drill to, you know, the resident or fellow, come up that side. And then what I'll do is I'll start, you know, usually at the 7-1 level, and I'll use a 2 Kerrison, and I'll start to like bite any remaining eggshell of bone, or any underlying ligamentum flavum. The other thing to remember, the lamina is thinner at the inferior edge and thicker up here. And when you start to get up into the area of the joint, you get the overlap of the 2 lamina. And so you just, if you need to, you can run a small upgoing curette under there, just to make sure you have your planes clearly identified. And then sort of the fun part is afterwards is pulling off the lobster tail. And once I have this all loose, I'll gently elevate this up off of the dura. I don't just rip it off in a ceremonious way, but I'll gently do it. And then I'll use number 1 Penfield or an inverted 15 blade to help release any areas of adhesions, which there oftentimes are. And then usually afterwards, I'll, you know, do a motor revoke potential and irrigate and so forth to get the whole wound cleaned out. If there's areas of like bony bleeding along sort of the facet joint, obviously we don't want a post-op epidural collection. I'll use Hemazorb, which is a resorbable bone wax that you can kind of gently put in there with a 4 Penfield or your instrument of choice, just to get everything nice and dry. Then at this point, what I'll do is I'll go and do my decortication. So, you know, because once you get your screws in, you're sort of limited to drill around here. So I'll get in here, decorticate all the lateral masses. I'll decorticate into the facet joints, make sure I have a good surface area for bone effusion. And then I will put the screws in. And so the big thing is with this, and I'm really particular, anytime the cord's out, nothing gets passed over the wound. I make sure everybody passes things to me sort of, down here, in the thoracic spine. So nothing, drops onto the cord. Never say never, because sometimes that stuff happens. And another thing that you can kind of do here in sort of your screw selection is a lot of the vendors have, different tulip heads, which have a favored angle in one direction or another. They all have a various swing to it, either medial, lateral, cranial, caudal, and you can use those to your advantage to help everything line up. And they're particularly useful sort of like at the top of the construct. If you're doing C2 or at the bottom with like T1s, you can maybe flip them in medially a little bit if your screw had a more lateral starting point. And then when I put the rods in, I'm really particular about this, and I want to make sure that I'm putting in rods that are contoured to the anatomy. So you're trying not to reduce these screws. These screws don't have a great pull-out resistance. So if you're trying to do a deformity correction, I try not to do it by just using the screws, except maybe in the setting of trauma. But a lot of like the correction is done under the table by repositioning the head or putting them into a favorable position before the case, or using bivector traction. That's kind of a whole talk in of itself. The other thing I'm really particular about is, it's sort of the end of the case, and, just you don't want to be too aggressive with, moving things over here. When I put the rod in, I try to be really cautious, or if, trainees doing it, be really cautious. So, nothing, falls onto here. When you're putting in, the set screws, that's another opportunity for things to fall off. The end of the inserter, so you have to be really cautious with that. Make sure if they don't have a self-locking device on the inserter, then you put some bone wax on there. Get all your set screws in, then do your final tightening. You do another set of motors at this point. And then what I'll do is I'll place in the bone graft, the autograft, the allograft, or whatever it is you're using. What I'll do is I'll place, that out laterally. I'll try to pack stuff into the facet joint, and then I like to use one of the DBMs, and I'll go medially, and I'll kind of pack it under the rod on this side. I place Fibrillar, which is an oxidized cellulose sheet. I put a layer over the dura just to give yourself sort of something in case you ever have to come back, which will make peeling everything off a little bit easier. Another thing that I do is I put a 19-round Blake channel drain in. So these are huge honker drains, and because what you want to do is make sure that any blood that continues to collect in here ends up going out rather than pressing on the cord. And I'll generally leave those in for about 2 weeks. I don't like the smaller Hemovac ones. Sometimes those clot off. And so I've been kind of using these for a bunch of years. I got turned on to it by my plastic surgeon a while back, and yeah, they're fantastic. And then after I remove the retractors, I always go back and I'll pull the muscle layers over. I'll look for anything that's bleeding, and I'll make sure that none of the bone graft kind of flipped out over the lateral recess and fell onto the cord. And if it does, which it oftentimes will, I'll just make sure I pull that back out, and I'm happy with everything one last time. Moving on to laminoplasty. So, this has been around for quite a while, originally devised in Japan, is a non-fusion alternative to decompress multiple levels of the spinal canal while avoiding post-laminectomy kyphosis. So there have been various versions of this over the years. There was this Z-plasty version here, which, if you can imagine how painstaking it was to cut this and this, it really, we played around with these when I was in residency just to try them out. And I happened to have a mentor who was Japanese, so he kind of really loved kind of flexing these little different techniques, and they're actually really challenging to do. Kurokawa developed this spinous process splitting technique, which is commonly known as the French door laminoplasty, where you open up the middle and you put these green stick troughs over in the corner, and then you split it open this way. I also did a few of these when I was in training, and they were horrible. It was just a lot of work, and I don't think it was really worth it in the end. But if you want to spend 8 hours doing one of these cases, yeah, it's there. And then Hirabayashi kind of came up with this other technique, and it's the open door laminoplasty. And I think this is the one that we most commonly use today. And this is where, you know, you do your bony work in the lateral gutters. And what you'll do is on one side, you'll come down here and do a complete cut. So you'll go all the way through, just like you do with your laminectomy. And on the other side, what you'll do is drill through the outer cortical cancellus and thin out the inner cortical layer. And you'll open up the ligaments on this side. And then what you can do is split it. I probably modified my technique over the years where I'll actually leave the ligament, the inner spinous ligament intact above and below, and these still flip over just to give it like an extra area here. And so one of the nuances of doing this, since we're not doing a fusion, as you're doing your approach, you want to avoid violation of the facet capsule with a cautery or anything else that you're use any other instruments such as a cob or curettes as you're getting this exposed. So that's a big thing that you want to do. Similar to the laminectomy, you want to delineate, you know, between the lamina and lateral mass. And then there's a lot of different vendors that have, you know, various instrumentation to put in here. The one I happen to use, what it does is you end up marking out with a guide the entry point for a little screw for the lamina. And I'll use, it has a very small drill bit, sort of 1.5, and it's set to a predetermined depth. So you'll pierce this in here. And then what we're going to do is you're going to place that laminar screw, and I'll do those before I do the drilling. Then I'll come in and do, you know, one side, then the other side. On the side that you're going to put the screws, obviously, that's going to be your full thickness cut. I'll use the kerosene to complete that, and then you swing it open. And there's a couple different ways to do this. Usually what I'll do is I drill through this segment. I'll kind of use my finger and I'll kind of push up on the spinous process just to get that to crack open. It's pretty satisfying. And I'll sort of do it as I go down. And as I said before, I'll leave those inner spinous ligaments intact. And as I do this, I'll always check a motor. The other thing I'll sometimes do, if depending on sort of how much lordosis that they have, and I'm worried about sort of cord flow back, I will do maybe like a C4-5 foraminotomy, just to make sure I'm not going to get a C5 palsy. It's the other little nuance. And then this is sort of the little plate system that I use, and then I'll put the plate in, and these come in a variety of sizes. This one in particular has a little sort of flange that comes under here that holds the underside of the lamina, and then the top part has this pickle fork, and then you can use either cranial caudal or side to side small screws in the lateral mass to hold this open. And then, you know, here's just some axial views of how we do this, you know, and so I think one of the nuances with this is like you want to avoid straight up and down, and the approach for all of this is sort of, you know, being perpendicular to the angle of the lamina at this level as you do this. And you know, this is the spring test as you're doing this. Again, I just use my thumb or finger to pull it over, and then that's how you know you've got enough of the release on this side. And again, it's a pretty satisfying thing when you're able to kind of pull that over. Some of the vendors have sort of a little integrated piece of bone graft you can put in here. So the hope is that, you know, this would unionize across here. And that's kind of what your final construct looks like. You know, you can see sort of the green stick over here and the opening here, and then, you know, the full cut side over here. Some of the things with this is you kind of need to think about sort of T1 slope. and the prediction of postoperative kyphotic malalignments after laminoplasty, because this is what you want to avoid. You do laminoplasty on somebody and they end up with this. And so, anytime I get a T1 slope over, 30 degrees, I start to get a little bit thoughtful about, what I'm going to do, and that's probably not a case for laminoplasty. I think historically they always said if it's a straight to lordotic cervical spine, you do laminoplasty. That's the way I was trained, but T1 slope definitely has a big impact on that. So wound closure. Again, these things have a propensity to break down for a number of reasons. Number one, there's a high tension load at the wound edges here, so all this wants to pull apart. You get this muscular diastasis in here. So this is a patient who had surgery a while back, but you can see how these two muscular bands pull apart. And there's a lot of dependent edema from laying on the spine, and pressurized ischemia from wearing the cervical orthosis. And sometimes the neck habitus makes a very difficult closure for you, and you get these kind of sharp A type necks here. So I use wide suturing to get the muscle bellies together, right? And I sew them over a drain so you don't have a fluid collection kind of pushing out through these. I also use Ethibond. I'll intersperse Vicryl and Ethibond, so the Ethibond doesn't dissolve and it stays in there forever, but it really helps to hold these things together. And I kind of switched to doing that after I had some of these patients come back for their 6 months. And after the sutures dissolve, it doesn't matter if it's Vicryl or PDS, they can kind of pull apart. And so now I've been putting some Ethibonds in there. It just helps to keep those muscles closely sewn together. And then I'll approximate the semispinalis and splenius capitis in a separate layer. And if it's a patient with a thicker neck or it's a juicy wound, sometimes I'll put a second drain in. I'll put a 15-round Blake between the deep and the superficial muscular layers. And then down lower, what I'll do is I'll attempt to get the serratus or rhomboids together, and I'll actually try to tag them to the spinous process. If you've ever looked at some of your post-op patients and you've had them kind of lift their arm up over their head and so forth, you sometimes get this scapular dyskinesia because of the way, one muscle moves, and if it's attached to the one on the other side, they kind of get this really weird thing going on. So I'll try to reattach these to where they came from rather than just sewing them together. And then I'll do a multi-layer closure on the skin. So I'll do the dermis with a monocryl, and then I'll do horizontal mattress sutures with a 3-0 proline to detension the wound edges. Again, this is something I learned from working with plastic surgery over the years. And this is, in fact, how I close like all my posterior cases. All my deformities get closed that way. And so it's really helpful. And so this is what I call the water ski technique. Sometimes you get these big thick necks and you get these deep creases and it's hard to fold. So what I'll do is I'll place heavy suture anchors out here laterally, right? And then I'll just lay back. And so then when you pull on these, you can see, it goes from this to this. You can open that up so you can get into these little crevasses and get things closed up nice. And then when you pull on this one, you can get in there as well and just lay back on it. And then sort of wrapping it up, what I'll do is I will re-sterilize my wound before I put on a dressing, and I'll use DuraPrep around the wound edges and up to the surgical field. I'll let it dry. I'll place, 4x4 fluffs over this and then an Ioban dressing. And I kind of stole this from Peter Newton and the kids. I'll leave the dressing on for 2 weeks. Don't take it off. It's like a Christmas present. Don't open it. Nobody look at it. And what we'll do is we'll pull it out in clinic 2 weeks post-op, and we'll take the drain out. And then what I'll do is within these high tension wounds, I'll leave the sutures in sometimes for 4 to 6 or even 8 weeks, just so, you're not breaking down the goal of detensioning the wound edges. And so usually like the PA will just kind of see that patient every 2 weeks and get them taken out. The reason I like those horizontal mattress sutures is nothing is overlying the skin edge. Like staples press on it and they start to erode away. You get all these areas of like maceration and so forth, and the skin gets irritated by the metal. But using these prolines are really well tolerated. Another thing I've done on occasion is I'll use one of these clavicle straps. You know, if people have really sort of rounded shoulders, you know, it increases the wound tension. So occasionally I've actually put people in these figures of 8 just to help keep the tension off the wound. Yeah, and that's what I got to say. And but last 2 weeks ago, we had our USA Adaptive Open competition in Oceanside. It was really awesome to get a bunch of my friends out there, you know, single, double, triple limb amputees, people with spinal cord injuries out there surfing in the water. So maybe next year, some of you guys can come up and hang out. It's good stuff. And that's what I got to say. So I'm gonna get back to this.
Thanks, John.
Stop sharing, and then we'll go back to my lovely face here, I think.
That was great, bud. Thanks for doing that.
Yeah. Lots of nuances to this, and even positioning is a whole nother talk in and of itself, just getting people positioned and so forth and do a proper thing. And I'll probably add that in there for next year.
So are you still leaving your deep drains in for a couple weeks?
Yep, 2 weeks. Yeah. I take it out just in the office at 2 weeks.
And irregardless of how much output?
Yep. Yeah, usually by 2 weeks they slow down. Yeah, I kind of learned that. Like one of my friends is a plastic surgeon, and he would do all these abdominoplasties, and he's like, no, I leave the drains in. And yeah, one of my neighbors at one point had an abdominoplasty by him, and she'd come over to the house and she'd have her drain and she'd kind of swing it around. She was actually a eye surgeon, and she was like, yeah, I got my abdominoplasty. You just leave the drain in for 2 weeks and then we just take it out. And I think that's similar to like what some of the peds guys do as well.
Yeah, no concern about infection risk though. Abdominoplasties don't have fixation.
Yeah. You know, I've never had concerns about infection with them. Again, I leave them under the dressing. And this was something interesting I did, because I think on one of the SRS adult deformity committees, remember we looked at somebody's protocol and, you know, oh, sorry, I just had some spicy juice. They were, you know, re-prepping with the DuraPrep. And so I did a little pilot. I had patients come in. I had about like a dozen patients. And what I did is I swabbed underneath the DuraPrep when we took the dressing off, and I swabbed outside. Obviously outside, the skin flora was pretty prominent, and the ones on the inside were still relatively clean. So yeah, I've just gone to leaving those drains in, and I haven't had any problems. I think way back, I had one patient with a Proteus mirabilis, which is a swarmer, maybe get into the sort of more superficial tract, but that was prior to, you know, me leaving the IABAN on for a couple of weeks. So I haven't had any problems, and I'm knocking on wood right now.
Yeah, I got
it.
All right.
Tons of pearls in there, Don. Yeah. Appreciate it.
Yeah, lots of little nuances.
Yeah, I think we all have struggles with those, so I think it's great to see all you've gone through to make it what it is now. So lots to learn.
Yeah, absolutely. Awesome. Well, everybody have a great Monday.
Yeah. Thanks, dude. Thanks, guys.
Thanks, Don.